At this time, we'd like to transition into the knee osteoarthritis panel. So let's bring on our panelists here and we can kind of get started. Hello, gentlemen. How are you? Good to see you.
How you doing?
You guys all look very, very dashing in your virtual element there. This is Dr. Bowen here. He's currently on the International Space Station. We have Dr. Carley down here and Dr. Farr up here in the top right. Okay? So we're going to present a couple cases here for this panel discussion, and you can kind of weigh in on how you would utilize orthobiologics in this patient. Now, to not get bogged down in the details, let's try to kind of keep a big picture view of this. Dr. Bowen, that should be easy considering where you're sitting in space right now, but you're going to give us, we can get the global perspective of kind of how we would utilize biologics rather than getting stuck into the imaging details and maybe surgical things of that nature, okay? So case number one that we have here is a case of mild osteoarthritis, and here it is. We have a 55-year-old active male cyclist with a history of ACL reconstruction at age 40, BMI of 23, presents with 1 year of dull, achy knee pain, rated 3 to 5 out of 10. Knee x-ray shows Kellgren-Lawrence grade 2 medial compartment knee osteoarthritis. Thus far, the patient has tried extensive PT and conservative care, which provided some benefit, and they've done an intra-articular corticosteroid injection with approximately 2 to 3 months relief. The patient would like to avoid any surgical intervention, but is interested in other options to help him stay active and continue cycling. So Dr. Bowen, why don't we start with you? How would you kind of approach this patient from an orthobiologic standpoint?
So, always we're talking about orthobiologics specifically with the 50,000-foot view, but we don't want to forget, did they actually have, quality therapy? Did someone look at their kinetic chain? They had a corticosteroid injection. They did have some good relief. Generally, insurance companies will cover hyaluronic acid injections, so I would at least, go with what they have covered by their insurance as an option for discussion. After that, if they're really, saying, I came to you specifically for regenerative treatment options, I think someone who's got mild issues, very active, to have a low downtime with a peripheral blood draw and trying a PRP prep, I think is probably the first simple option. And even with people with severe OA, I think it's a simple and good initial step where people can get months to years worth of relief. So that would be the first thing I would discuss with them, as well as incorporating a global approach.
Gotcha. And Dr. Carley, same to you. How do you approach this patient from an orthobiologic standpoint?
Yeah, I think Jay's points are valid, and I would approach it similarly. I would add, relatively young, healthy, active male. I would ask about mechanical symptoms. I don't tend to make decisions on orthobiologics based on X-ray. So I would typically recommend an MRI prior to making that decision. And particularly for looking for any unstable fragments, unstable meniscal pathology, cartilaginous pathology, a lot of floaters, things like that, all of which work against us. But unlike Jay on this one, I tend to use BMC intra-articularly for knee OA. We've just had such good luck with it. If they're healthy and have high cellularity in the medullary cavity, we like to put those cells to work. So I would tend to approach this with BMC. And also at age 55, the other thing I would do is to look to see if this patient hormonally is optimized. We believe that the hormonal axis has some impact on the outcomes of our cellular therapies. So is he on TRT or test therapy? What's his hormone level look like? What do the rest of his laboratories look like? What's the nutritional status?
Gotcha. Very interesting. And Dr. Farr, to you, how would you approach this patient?
So I'd agree that we don't want to just rush in and throw orthobiologics at somebody without knowing a diagnosis. So I really agree with David on looking for mechanical factors. What really concerns me about this patient, he only has grade 2 medial compartment OA, and yet he's coming to you with these symptoms and he wants to cycle. Well, I usually tell my OA patients to go cycling and it doesn't hurt them. So there's something different about this patient. Maybe he needs to get his toe clips fixed. Maybe he needs quarter floor. As far as my orthobiologic approach to him, I'm going to start off what is the most cost effective for him. And for me, that's low white count PRP. And then if he responds to that, and we can have a discussion, do you want to repeat it or do you want to go to one of the other cell therapies, as we all know?
Gotcha. At any point in this kind of active patient that maybe is looking to be a little bit more aggressive with their intervention, Dr. Carley, you had mentioned that you like BMC, but is there anything that would cause you to go one way or the other as far as maybe trying an adipose or trying PRP, or do you primarily with this active patient really go with your BMC?
Yeah, I may be a little different to some of my colleagues in that we've just had markedly stronger duration of outcomes with BMC over PRP, and that's not to say PRP is not an option or a good option. I think it's fair that often we'll be looking at a multiple or staged PRP intervention. A single intervention sometimes is not enough to really carry. So you could make that kind of point. I do not use adipose currently. We're still kind of eyeballing the regulatory status surrounding that. So for the time being, we're not pursuing that as an option for our patients. I like BMC for knee OA. I think data is starting to come through. Our anecdotal results in the clinic are kind of mimicking what we're seeing in clinic, which is strong and sustained benefit in these folks, especially younger, active, and healthy.
Gotcha. Good to hear there. And Dr. Bowen, how about you? How do you consider other biologics in this kind of active patient here?
Yeah, I think the first thing is a discussion with the patient on, cost and the potential benefits. And if we look at it, we're all talking about what our anecdotal data is, and that's a problem. We have a certain amount of data that's been published. We talked earlier in the conference about, how do we classify our PRP? PRP has a lot of good data on mild knee OA, so grade 1 and grade 2, maybe not as well for grade 3 and 4. It's a less expensive cost. We've seen in those patients that respond, they have a very good durability of it. And if the patient just says, listen, I want a one and done, I don't want to come back to you, I would have that longer discussion about adipose or bone marrow aspirate. But the problems we have with PRP classification is just compounded with bone marrow. What are we actually injecting in these, and limited studies? So I think for this panel and the people at large viewing it, I think the biggest thing we have to remember is, we're going to talk about a lot of protocols, what we see, but it doesn't matter. If you're the person there, try to look at the literature, what we as, so-called experts have said, our experience, develop your own protocol, follow that protocol with your unique population, your unique skill set, your diagnosis, and see what your outcomes are and follow your outcomes, because ultimately that's what matters is patient outcomes. Patient doesn't care if someone's study down the road saw people and you don't respond to it. So, and then just like my colleague said, I think it's really important to take that pullback view and not get too hyper focused on the biologic. But there should be sometimes very simple things that the therapist either weren't doing or the person who prescribed it, the therapist is doing some shake and bake stuff, and it's really just not what the problem is.
Gotcha. All good points all around. Let's move on to case number 2 here. This is a case of moderate OA and Chondromalacia Patella. So we have a 50-year-old active female with a BMI of 19, presents with chronic left anterior knee pain rated 6 out of 10. That worsened 6 months ago. Knee X-ray reveals Kellgren-Lawrence grade 3 tricompartmental knee osteoarthritis. Left knee MRI showed evidence of moderate osteoarthritis and grade 2-3 Chondromalacia Patella. Now, thus far, the patient has maximized all other conservative care, including bracing, medications, and PT for greater than 3 months. The patient wishes to avoid surgery/hospitals because of COVID risk, but would like to return to gardening and her typical active lifestyle. Same thing. Dr. Farr, why don't you walk us through kind of what your orthobiologic treatment algorithm might be in this situation?
Well, once again, I'd like to back up and look at the patient and get some additional imaging. I think most of the patients deserve that. As far as my approach to tibiofemoral versus patellofemoral, patellofemoral responds many times better to therapy, and yet at the same time, at least in my experience, it has not been responsive to some of the orthobiologics. I think some of that is their pain is actually bone. You'll see that on the bone marrow lesions associated with chondral lesions. If that's the case, then I believe in orthobiologics, and that potentially could be an injection like a bioplasty into this area of bone marrow lesion of patella. So to back up, I think my overall approach to all these patients that I try to give them the cheapest first option. I'll be interested in what the other panelists say, but if I have somebody that responds to PRP, then they many times will respond to the other orthobiologics. If they don't respond to PRP, maybe this is a dry joint, maybe they have worse OA, maybe it's bone pain and not generalized OA of the knee, then those patients may not want to go on to additional, more expensive treatments.
Gotcha. And before we swing this question or this case around the horn here, we do have a new addition to the panel. This is Dr. Danielle Offiero. Welcome to the panel. Thank you for patching in. So I'll just repeat the case one more time just to make sure that you're up to date on what it is. But we have a 50-year-old active female who presents with chronic left anterior knee pain rated 6 out of 10 that worsened 6 months ago. Knee x-ray showed grade 3 tricompartmental osteoarthritis, and the left MRI showed evidence of moderate OA and grade 2-3 Chondromalacia Patella. So Dr. Bowen, why don't you go ahead and give us some of your comments on your orthobiologics approach with this patient?
I think the same as Dr. Farr said, is you pull back a little bit and find out what's going on. This person's got OA, it didn't just pop up. It's fairly severe, but 6 months ago she's got problems. So why did that occur? Did she have a twist? Did she have an injury? Did she start kneeling when she does her gardening? Get more details about what's going on. And then again, look at imaging to see, is there some clue about what's going on? Definitely look at her kinetic chain and see what her, status is. From there, I think it is a little more difficult. If all the mechanical stuff is going well, that she's got patellofemoral problems and she wants to hyperflex the knee or kneel on it when she's gardening, it's going to be a little bit more of a problem. Talk about just simple strategies. But someone who's got more severe OA, I would consider, PRP at least in the initial discussion, and then it's a cost versus duration kind of thing. And I would probably talk a little bit about adipose, but I see how you put in this very low BMI. Although even with low BMI people and athletes, very high level athletes, we haven't really had that much of an issue with obtaining adipose, especially in some of the systems where you don't have to get a large volume. And if you think you may have an issue, whether it's skin or otherwise, you can do an ultrasound and just see, is there any fat in that area of your planned harvest site? So, I've just had a little more patient, adoption of adipose, because they lean in when you say adipose and a free tummy tuck, and they sort of roll backwards in their chair when you talk about a bone marrow. They feel that it's just going to be painful. I still, even with that, I try to lay their fears and I say, listen, they're both really similar, just different types of pain and areas. So as long as you get the buy-in and discussion of all different aspects.
Gotcha.
But it could be a difficult patient because of that patellofemoral component.
Yeah, and Dr. Carly, no adipose, it doesn't seem like in maybe your algorithm, but how would you approach this patient?
Yeah, I think adipose could be attractive here. It wasn't really that it's not clinically attractive to us, but for other reasons. But I think all great points, I think, by everyone so far. And another issue is she peri or postmenopausal? She's 55, I believe it is, with a BMI of 19. So, again, what's her hormonal status? What's her dietary status look like? Is she getting enough protein? Is she vegan, for example? That's not a terribly unhealthy BMI, but it is low and something I think worth consideration. If her bone density is not high, as Jack said, that could certainly be playing a role from a bony perspective as to pain generators. Similarly to what we've heard, we have not had as good of results with anterior compartment disease than we have with medial or lateral compartment disease. But I also think there aren't a ton of great arthroscopic options, or certainly not joint replacement options for isolated anterior compartment disease from a surgical perspective. So from that standpoint, and failing more conservative injection options, I think biologics are attractive here. But again, I think we need to look at the bigger picture in this one.
Great points. And Dr. Offiero, turn it around here to you.
Chondromalacia patella, when it's mostly in that patellofemoral joint, there could very easily be some tracking and extensor mechanism, leading up to why all of a sudden this pain occurred. You want to ask if the patient's been sitting more, maybe their IT band got tight, or they stopped wearing their orthotics. All of those issues have been worked out with physical therapy, and she's still having issues. I would check with the musculoskeletal surrounding soft tissue, like the patellar and quad tendon attachments and the distal IT band. And if I see any evidence of tendinosis or IT band tender in these points, I find that doing the PRP, not only into the joint, but into the surrounding medial retinaculum, the quad and patellar tendon sheets. And
gosh, it looks like we're losing you there a little bit, Dr. Offiero. But now, Dr. Farr, you had mentioned possibly doing some sort of intraosseous technique to the patella. Dr. Bowen and Dr. Carley, do you utilize intraosseous techniques for chondromalacia patella?
Well, let me back up. I'm using it for a bone marrow lesion. I'm not using it for chondromalacia patella.
Good clarification.
Discussion.
Thank you for that.
Yes, I think it's a great point. I think, I believe it was last year, someone presented on intraosseous application in patellar tendonitis, which was interesting. I do not for patella. If we see bone lesions in the medial or lateral compartment or in the trochlear groove, we'll consider it. But I like to see those T2 hyperintense signal changes before we would consider it. Hernigo's data is very interesting, and you could make an argument that perhaps intraosseous for moderate to advanced OA has some appeal. But I think from a procedural perspective, looking at risk and looking at cost, intra-articular, if there's no bony lesions on MRI scan, probably is still most attractive here.
And Dr. Bowen?
Yeah, I would sort of echo that. We haven't really adopted interosseous beyond AVN because we've had such good success with treating it, interarticularly or otherwise. Whereas Dr. Alfieri alluded to, looking at the kinetic chain and the whole knee joint, whether it's a pes anserine or there's proximal or distal polar patella issues that are just missed with the typical examination that people do, that you may find that there's a different pain generator that the imaging or the initial assumption is that this patellofemoral is not really the case.
Gotcha. Great points all around there. Thank you for that. Let's move on to case number 3 here. This is a case of severe OA with meniscal pathology. So we have a 75-year-old male with a past medical history of uncontrolled diabetes and morbid obesity with a BMI of 40. He presents with chronic severe bilateral knee pain. Bilateral knee x-rays show grade 4 and severe tricompartmental osteoarthritis. Now, the knee MRI also shows evidence of degenerative meniscal tearing on bilateral lateral meniscus. The patient has been told that he is a surgical candidate for knee replacement if he can lower his BMI less than 35. Thus far, the patient has been unsuccessful with bracing and PT and medications, and his weight loss has been limited because of pain during exercise. How do you approach a patient with this kind of clinical situation? And Dr. Alfieri, why don't we start with you?
So for this particular patient, who's an elderly gentleman, really probably stuck in a pain cycle, can't lower his BMI because he's in so much necessary. This might be a situation where the biologics, if not lasting for the long haul, could at least get him into a position where he get to the point where he could get a knee replacement if the biologics are not sustained. But in someone like him, I would consider fat, give a lot of it to give. And, we typically look at the age and BMI to determine bone marrow versus fat.
Gotcha. Great points there. I'm going to, just because of technical issues there, we're going to pivot over here to Dr. Carley. Dr. Carley, why don't you comment a little bit how you might approach this patient from an orthobiologic standpoint?
Yeah, I think this patient's very interesting because it raises a number of issues. With uncontrolled or poorly controlled diabetes, we want to know what a hemoglobin A1C looks like. Our cells and our platelets, for that matter, are subject to glycation just like everything else in our diabetic patients. And a 75-year-old who may have had diabetes, whether it's adult onset, type 1 or type 2, we don't know, but we may have an issue with cellularity and or the potency and therapeutic efficacy of his cells because of the comorbidities. So it's certainly a factor. That said, I don't know that he's a great total knee replacement candidate either. Is he a vasculopath? Does he have cardiovascular disease? An EKG would certainly be warranted. A full medical workup here would certainly be warranted, whether we go non-surgical or surgical in nature from a biologics perspective. And then another thing I would add, something I think that's very interesting, I think we'll be hearing more about in the years to come, is senescence. So with comorbidities, and particularly with systemic illnesses like diabetes, we lose a percentage of our cellularity in our cells to senescence. That can be measured, and it's an emerging area scientifically that I think will have impact on our cellular therapy. So may not apply today, but something to think about in a patient that has a lot of pre-existing diseases, and that's going to impact our decision-making. If he's not a good surgical candidate, can't lose weight, I think Daniel's point about pain limiting his ability to be effective with that, it may be worth a try, but I certainly counsel conservatively here, knowing that there's a lot of variables working against us if we decide to pursue biologic therapies on any level.
Gotcha. Very good points. And the senescent cell is very interesting there as well, echoing a little bit of Johnny Hewart's stuff that he has been talking about. And Dr. Bowen, case to you.
So I'll start throwing a left curveball. We talk about orthobiologics, but in some of these people who are old, who, as we already mentioned, have some issues with potential response to biologics, and the price, I would initially actually start with some ozone therapy into the joint. It can help with nociceptive pain, potentially give him a short-term, reprieve so he can start exercising and doing some other things. If you found long-term benefit from that, as Dr. Carly said, you look at bone marrow and you're going to have a reduced cellularity or maybe quality of the cells, which you don't see in at least the basic signs of adipose. He has enough adipose to take. And with the meniscal issues, I think that we've had really good success with patients who have this tricompartmental meniscal interference and problems with using fat. The other thing is, it seems like everybody walks in their office saying, I'm a total knee candidate by my surgeon, whether they have grade 1 or grade 4 OA. This guy's sort of fortunate in a way that the surgeon maybe doesn't want to take him on right away from his comorbidities. So again, as Dr. Carly had mentioned, treat all these patients in totality and not like hyper focus on the orthobiologic.
Gotcha. And in your procedural technique, will you focus on the degenerative meniscal tearing?
Yeah, I would. Especially if you can see it on ultrasound, but I would probably put some of the adipose sort of in the middle of the joint and then see if I go laterally along the joint, especially on examination. If there's collateral ligaments or coronary ligaments by the meniscus that are in a particular area, put just a little bit in each of those. It seems like they do better with multiple injections than just sort of dropping it right in the center. Gotcha.
Now, Dr. Farr, let's move around the horn to you here. Same case. How would you kind of approach this patient?
Well, I agree with the thought process. I think KL4 scares everyone, and you really need to be very honest with the patient about a potential lack of response. I'll throw a couple other curveballs out. One is there's some new interesting research going on with capsaicin to basically kill the intra-articular nerves. Now, they can regenerate, but still the patient can have pain relief. The other one is looking at extra-articular, some of the geniculate nerve blocks. So those are a couple things to throw out in this particular patient. Once again, this gentleman, 75, he may have, we don't know his finances, so we have to do, what is most economically, what he can afford, because many insurance companies cover none of the orthobiologics in my area. We haven't talked about amnion. I saw it was only used in 2%. We just published a RCT comparing it with HA with interesting positive results I'll present later. So that's a nice, easy, convenient because there's no harvest. It's just thawed out and injected. And I think we all need more research for all these different options.
Absolutely. Well, great perspectives all around. We really appreciate you taking part in this panel. That's all the time that we have for right now, but thank you so much for logging on and joining us today. Great perspective. So thank you so much.